Good afternoon and welcome to the London Ambulance Service Public Board meeting. This meeting is being live streamed and will be available on YouTube for a few weeks to come. So welcome to members of the public who are looking at us on YouTube, and welcome to board members. Today we have no apologies for absence. Do we have any declarations of interest from board members? No, thank you, none. Can we move please then to the minutes of the public meeting held on the 24th of November? If we could take them for matters of accuracy first, please, on page 1. Page 2. Fergus, did you want to ask, or was that quite difficult to tell from here? No. Page 3. Page 4. 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. There are no points of accuracy. Can I take those as an accurate record of the meeting then, please? Nodding heads. Thank you. So those are approved. Thank you very much. So turning now to matters arising and our action log. Right. So we have an update on the annual financial plan. Lorraine.
Yes, Chair. So the action was a request to itemise the way in which the capital programme might need to be prioritised in light of the revised CRL. And the action note, which is actually on the second page, convene page 23, it just confirms that in fact that prioritisation wasn't necessary in the end. So events are sort of superseded. We've had some slippage as a result of the COVID second spike, and the value of that slippage was actually offset the amount that we were looking at. So in fact we are proceeding with the full programme, but just with a slightly longer time scale.
Okay, thank you. Can I remember my board colleagues that the public are listening to this, and we are a myriad of acronyms, so if I could ask people to remember to spell out what those are. Thank you.
The resource limit was the CRL.
Thank you. NHS 111 services. I think a bit of delay in this review because of COVID. Kadir even.
Thank you, Chair. That's right. The intended deep dive we've had to pause while we've focused on operational pressures and performance. Can I ask that we carry this over to the next board meeting, and I can give you an update then?
Very happy to carry it forward. Would like to be sure that it's going to be at the March board.
Understood, Chair.
Thank you very much. So before moving into the main board agenda, where we are very much focusing today on our COVID response in relation to our people in the subheadings that we will cover, the quality and clinical care that we've been able to deliver, and our performance in COVID. And that is really the main thrust of this agenda today. And I should advise that we did hold an extraordinary board meeting on the 12th of January with the sole purpose of covering these areas to assure ourselves that the service that we are providing to the public is as safe as it can be in the circumstances under which we are working, and that our response to our people is that we are looking after them and making sure that we are able to do everything we can for their welfare. So that is very much the focus. So I'm now going to hand over to our Chief Exec, Garrett Emerson, to talk us through our response, or to introduce it, I should say.
Thank you indeed, Heather. Good afternoon, everybody. So we're going to start talking about our COVID response by focusing, as Heather says, first of all on our people, then our quality of care for our patients, and then finally our operational performance. So I will lead the element of that. Chief Medical Officer Fenella Wrigley and the Chief Quality Officer Tricia Bain will lead the second element of that, and Kadir Mir. So will lead the third bit.
Thank you.
In relation to people, there are 4 areas I want to focus on, which are highlighted on the agenda, and some information obviously been circulated in the papers in advance of the meeting. They relate to our overall levels of staffing sickness and absence due to COVID, both in terms of illness and, of course, in terms of isolations. Our progress with regard to vaccinating our patient-facing staff, to make sure that they can be as safe as they can be in going about their duties in relation to patient care. Thirdly, around what more we've been doing to look after and ensure the welfare of staff in this incredibly challenging time for the NHS as a whole, but obviously for the ambulance service in particular. And fourthly, what we've done to augment our communication across the organisation, accepting that obviously we need to maintain our levels of social distancing and isolation, but at the same time make sure that we are getting pertinent and timely information to colleagues, and also being able to answer questions and clarify issues and allay fears during what is and has been, I think, quite a scary time for people. Inevitably, second wave of the pandemic, it has been as challenging and probably more challenging than the first. The volumes of patient demand have been higher, the severity of illness has been higher, and the challenge for our staff who've been working incredibly hard for many months now is probably greater for all of those reasons, and also for the fatigue element of working through from the spring through the summer and into a long winter, which is not over yet. As Kadir will say, we're obviously on an improving trajectory in terms of both the strength of our performance and our resource capability, and thankfully levels of infection across London are beginning to go down slowly now, but we are far from over that, as you will hear in the newspapers and in the media, and we need to really re-emphasise everybody's support across London for maintaining the lockdown, maintaining the social distancing restrictions, and helping us to do our job. In relation to those 4 things, sickness levels now steadily reducing, hit a peak in early January at something over 20% of our staff being off for one reason or another, which obviously had a significant impact on operational performance. That is slowly coming down at different rates in different areas. At various times we've seen significant impacts geographically, particularly in North East London, because of the prevalence of the infection there. That had a disproportionate effect on our 111 services there, but that is now improved somewhat, we continue to monitor that. There is a steady downward trend across the sectors, but still overall absence probably more than double what we would expect it to see at this time of year. So that's still a challenge for us. In terms of vaccinations, we have been working incredibly hard since the beginning of January to vaccinate all of our patient-facing staff. There's information in the papers that were sent out in advance of the meeting, but I can tell you, as of today, the current situation is we have now 80% of our frontline staff have been booked in for a first vaccination at one of the 25 or so vaccination centres across London, and 56% have confirmed that they've had that vaccination, and we continue to work to offer every member of frontline patient-facing staff a vaccination. Closing in on that target. It's been a huge effort, fantastic effort from our wellbeing team, and Tricia Bain, as Chief Quality Officer, has led that work and may want to add further detail in relation to the section on quality and clinical care in terms of what we've done. But I just want to pay tribute to a fantastic effort across the organisation to make progress on that. In terms of welfare, one of the things we recognised at the beginning of this second wave was that we were going into it with an organisation already considerably challenged and considerably stressed from the number of months that we've been working to respond to the pandemic, and working in different ways, people self-isolating, working away from home, doing different jobs and so on, and working in different circumstances. So we felt we needed to redouble our efforts to support staff across this. Now, that's involved a significant scaling up of making available resources, food, for instance, for staff both in control centres and call rooms and also out on the road, with welfare trucks going out with considerably more extended hours to support staff, and also make available welfare support, counselling and other support, both in terms of through our regular channels, but also through additional support from organisations that don't usually support us, and particularly the airline industry has supported us through something called Project Wingman, which has enabled staff working in control rooms to access time out from the control room situation and access welfare facilities both in Waterloo and in a different way. We've done the same thing in Bow and Barking and Croydon, and we continue to look at as many ways as we can to support staff across this period. We held an additional meeting of our core leaders, our frontline managers, last week to look at what other opportunities there were to support staff and other things that they felt staff would appreciate, bearing in mind that we're going to be in this COVID pandemic phase for some while yet, and we need to support our staff to remain our resilience for some time to come. And the final thing that we did was to redouble our communication across the organisation. We've obviously had a number of communication mechanisms in place for some considerable time, but digitally in terms of the Pulse and the internal intranet messaging and the 3 times a week LAS TV Live question and answer session where execs answer directly questions from staff. We reactivated the COVID specific question and answer hotline outside of that so that people could ask questions online at any time they wanted, and we're obviously updating fact sheets and bulletins on a regular basis to keep people up to date with the most up-to-date clinical and operational information, and indeed about the vaccine as it was rolled out. We introduced a regular daily gold briefing for every shift to hear from the Trust On-Call Gold what the current operating situation was. We ensured that every crew had a beginning and end of shift briefing and debriefing in their local ambulance station. And finally, we introduced a daily 12 o'clock executive briefing where either myself or one of my board executive colleagues has updated from a strategic perspective to give staff the most opportunity to stay in touch with what's going on across the organisation and to understand the progress that we were making towards solving the issues that were particularly challenging over the Christmas and New Year period that Kadir will refer to. I think that's probably the main points I would like to highlight, Heather, but very happy to answer questions and provide further clarification.
Thank you. Are there any questions for Garrett at this stage? Whilst people are thinking, I think, Garrett, you would agree that we owe a debt of gratitude to those external organisations who funded the food, funded the airline work to support our staff and done it at short order. So really quite remarkable.
Yeah, absolutely. Once again, and a large number of organisations have been incredibly supportive to us and enabled us to provide a lot of this resource. So, yeah, really appreciative.
Right, good. Amit, you wanted to come in.
Yes, thank you, Chair. I guess a comment as much as anything else, Garrett. I think fantastic to see all of the work that's gone into the welfare side and the communication side during this time. I had one of the welfare calls with somebody from corporate services who was very appreciative of what LAS had done to set them up with the equipment for home working, so which was great. But they personally were struggling, and I'm sure they're not the only one, struggling with how to remain more connected to the organisation while they're working remotely, how to engage with their wider team, some of the more kind of I guess horizontal communications and the social side of work. And I think it will probably. We know that for a lot of our staff, they're going to be remote working for some months yet. So I guess it's just really a question around, do you think there are things we can be doing or should be doing around making remote working work, for want of a better word, beyond the sort of equipment and the setup?
Yeah, I absolutely agree. And I think there's something about the longevity.
Sorry, Garrett, you're coming and going. Could you? That's better. Thank you.
Well, that is. Yeah. I'll shout. I think the first COVID spike, it was on relatively very high levels of home working. Obviously, through the summer, we reduced that a little bit. Still, did you see Heather? You find it hard to...
It's tricky, Garrett, I'm afraid. I don't know what's happened. Your sound comes and goes.
don't know what that is.
But while you're sorting that out, I'm grateful to the non-execs who've joined in the welfare calls. It is something we can do as part of our golden thread of being in touch with the workforce. And I don't know if while waiting for Garrett, if anybody else wants to share their phone calls or messages they picked up. The person I spoke to was extremely well equipped at home with the office equipment. I was quite impressed. In fact, she ended up being worried about my situation at my home, whereas my own fault, but I wasn't as well set up. Jane, you wanted to come in?
Just whilst Garrett's trying to sort that out, and sort of a build on Amit's question. Sheila and I joined you last week at the staff advisory group, and one of the takeaways that I took away from that was that staff are now starting to mentally prepare themselves for when they may be able to return to work, and there was some concern, particularly for the corporate environment, how that might be set up for them. And how actually they do return to work, and whether that be on a phased basis, because a number of these people have been shielding for a long time, and they're concerned and nervous about coming back. So we talked at the meeting about needing to have a real kind of return to work plan that is safe for people and gives people confidence to want to actually return to the work environment when that time comes. And I realise that's not now, but it's clearly on people's agenda.
I think that's very helpful.
Can you hear?
Yeah, that's better. Yes.
Yeah.
Did you want
some interference on the line? Appears to have disappeared. Yes, absolutely. To both what Amit and Jane had said, I think there's quite a lot of work to do. In fact, I was having a conversation with Kim as People and Culture Director this morning about how we might go about doing that. I think there are a number of facets to this. There are obviously people who've been isolating for some considerable period of time and have been away from the workplace, others who haven't necessarily been isolating but have been working from home to minimise the amount of travel into the office. There are clearly some considerable benefits that we have derived from increased levels of home working in terms of work-life balance that I think people will see as a positive and want to continue. And there are also things that people will want to get back to and spend time in the office. And I think it will vary from person to person. It will vary from role to role. So what Kim and I have just discussed this morning was taking the People and Culture Directorate and actually doing a piece of work fairly urgently with every member of the team to discuss on an almost individual basis what people's ideal work-life balance or what their ambition might be in that regard, and then to try and triangulate that with where we'd like to go as an organisation, how that might work, whether if you're going to have increased levels of working in the longer term, will you have a whole team on one day to have a team day, or will you have one person from each team on each day so that they can work across teams? I think there are a number of things, and what we've certainly picked up is that there are some people who've thrived in the home working environment and some people who find it very frustrating and it can be isolating. So I think probably a very good place to start will be to look at the People and Culture Directorate and see how we can do that, and then work out how we reshape the office space and the office accommodation with that, because it's probably that we don't have the same type of office accommodation. We probably have fewer larger meeting spaces, more sort of private areas where people can break out or get together in groups when they do come into the office. I think there's a really massive change that we've got to get our heads around that we're just beginning to embark on. I'm
sure. So a lot of work from the exec, and obviously the frontline staff. We're going to hear about all their work in a moment. But we're grateful to the non-execs and execs who've joined in the welfare cause, because I think it is a good way of finding out from them. And clearly, I know you've picked up on communication, Garrett. It is key that people who are remote feel that they are really engaged in the organisation. I know you're trying to do that now. Thank you. Shall we move on to the next part of the Fergus, sorry. And then Mark.
Thank you, Chair. We may be planning to take this as part of the items that follow, But my question was around the concerns that have been expressed about the impact on staff of long waits in ambulances outside hospitals. There are issues around PPE, but just the general safety of that situation. Would you, Garrett, or will Fenella?
Fenella pick it up, I think.
What we're doing in that respect.
I think Fenella would pick that up.
Yeah.
Obviously, we made a decision at the board to enhance the availability of PPE for just that circumstance. Fenella, do you want to elaborate on that?
Yes, thank you. So we are aware that there have been delays outside hospitals, and at times there has been long delays where our clinicians have necessarily needed to remain in the back of the ambulance with the patients. We've approached this through two ways. The first and the most important is actually working with the hospitals to make sure that we can offload in a timely way, because the delays not only affect that patient but affect the patients that we're waiting to respond to. But in addition, the concern that was being heard very loudly was that the fluid-resistant surgical mask, so the level 2 mask, did not feel as if it fitted closely enough around the face for our clinicians. And therefore we took a decision to offer an alternative level 2 mask. So we did not upgrade against the national guidance, which has been reviewed multiple times in light of the new variant that has come out, but we offered a slightly closer fitting level 2 mask, which has been well received and has given greater confidence to the clinicians. But as I say, the key is to actually ensure that the patients are offloaded in a timely way so that they can start their definitive care as quickly as possible.
Thank you. And Mark, you wanted to ask, I've lost you on the screen. Where have you gone? Mark.
I'm here, Chair. I'm just above you on my
screen. Oh, there you are. There you are. Okay. To my right. Yeah. Mark, you had a question.
Apologies. I know it's a question we've asked before, but important we keep on track on it. We've still got 1/5 or 20% of staff who aren't consenting for vaccination. While that's very worrying, what are we doing to protect those staff? Do we understand the reason for their hesitancy? And what are we doing to protect them?
I can take that, Mark, and Fenella, if you want to come in and
okay,
I know might.
Thank you, Tricia.
So yes, we are aware. We are constantly communicating with staff. The locality general managers, the wellbeing team, are calling all staff to make sure they've got the information and to ask that they access the portal, because a lot of the issues we're having is people aren't going back into the portal to confirm whether or not they want the vaccine or they've actually had it. So we're doing a lot of communication, a lot of individual contacts to encourage people to have the vaccination. We know the groups that are not taking up the vaccine more than others are the BMA population in the organisation. They are the lowest recorded for consent and for taking up the vaccine. There are different reasons for different ethnic minority groups, which we are analysing the numbers. We are doing a targeted approach on those groups. We have a campaign setting out on Friday, which is nearly all day, drop-in centres for staff to identify what are the reasons, any questions they want to ask, but also trying to get BMA champions to encourage staff to have their vaccinations. However, as we know, this isn't mandatory, and we are logging and recording how many staff currently do not want to have the vaccine.
I suppose the other side of that question is the risk assessment, isn't it, then? Was that what you were going to say, Mark? Sorry.
Exactly.
Tricia, Fenella, who
risk assessments are part of the ongoing management approach to the health and safety of staff. So that should be part of their regular management contacts with their senior managers to carry on with those risk assessments around that are COVID related.
Mm-hmm. Okay, thank you.
I think it's more than that though, Trish, isn't it? As we go forward, we'll have a subset of staff who haven't been vaccinated, whereas others have.
Yeah.
And they remain a high risk of developing COVID.
Yeah.
It really does need highlighting.
Yes, absolutely aware of it, Mark, and we are focusing on it.
Thank you.
Good point.
Okay, Garrett, are we ready to move on to the next part of the report with Tricia and Fenella? Yes, so looking at quality and clinical of care, really important part. Which of you is going to kick off?
Sarah, I think, is going to start.
Yeah, so I'm going to start and then hand over to Tricia.
Excellent, Fenella.
Throughout the pandemic, we have experienced points of delay throughout the patient journey. And one of the key aspects that we have worked on in both this part of the pandemic and the previous is around how we work as part of the wider system in order to be able to ensure that we are able to manage each of those points of delay, minimise them, and therefore improve the patient's outcome and improve their journey and their access into definitive care. There are national safety thresholds, and we have on a daily basis monitored against the national safety thresholds. That is a surrogate for where we could see safety to be reviewed, but it gives us an entry point into the patients where we may want to look at their journey and see whether there were elements of it that we could have learnt from and improved. That's been done on a daily basis so that we are able to assure ourselves that the patient has had a safe patient episode, if not the quality that we would always want to deliver due to the volume of patients that we've been managing. We have set up a very robust oversight of safety and quality throughout the pandemic, including multiple 4 times a day clinical safety reviews, daily review of the incidents, as I've just talked about, looking at incidents that are raised to us by our clinicians, by patients themselves who contact us, by other healthcare professionals, and through the control rooms. We have continued to review patients who have had contact with us on one day and have then had a further contact within 24 hours to understand the decision-making process on the first contact. And we have worked very closely with colleagues across the wider system to understand how the whole journey for the patient can be looked at, not looking at each individual patient part in isolation. I'll pass on to Tricia to talk about the process that we've used.
Thank you, Tricia.
Yeah, so we're using the structured judgment review process, which was a nationally agreed process as part of the learning from deaths process, but we're using it for incidents. So we are looking at all of those patients who've reached the 2 times 90th centile, that's the national standard. What we do is categorise the patients who are likely to have higher harm levels, so patients with chest pain or potentially stroke symptoms. So we've categorised them into 4 groups. We review all of those individually, and if we believe there are issues with our clinical assessment or anything over and above delay, we will put them back into our serious incident process and declare them a serious incident if that is appropriate. However, we are looking at the overarching reasons around delay, and that's really important for us for now and for going forward in terms of, is there anything else we can learn in relation to our response times and our call handling times. But I will say what we are definitely seeing in the second wave is a reduction in the numbers of those patients who have had a longer delay because of call answering, potentially around 60% less than we had last time. So a really significant improvement around call handling. Clearly the demand we have had this time has had some issues around our delays, but we are looking at them all, and we have a group of people independent to the staff in the organisation helping us to review those cases.
So we should really recognise that the call handling has been better because of the actions that the executive could have put in place with Fenella to make sure that we can have more people to do it. But we've been blighted a bit by the height of the sickness levels in this second stage and the delays at hospital. But you've got processes in place.
Yeah.
Fenella, was that?
And I think the other thing I would call out is that the system working across the whole of healthcare and social care has been significantly better than we've ever seen throughout a winter.
Yeah.
What is very different to this wave of the pandemic compared to the first wave of the pandemic is the fact that it is in the middle of winter. So we are dealing with patients who have got winter illness as well as COVID. And whereas in the first wave there could be a an assumption that patients who had a cough and a fever may have COVID. This time we are dealing with pneumonias and with other respiratory illness, which has required much greater integration with the wider system to look after patients in the right place and to ensure that patients who need to go to hospital still are accessing healthcare. And that's through the big campaign of the NHS being open, so that patients suffering strokes, patients suffering heart attacks are still accessing the care that they require, which has been which has continued and is very positive to see.
Thank you. And you were telling me this morning that the patients are much younger than the first cohort and still very sick. And therefore, you know, if we are out on YouTube, people are listening in, a really important message to follow the guidelines, wear the mask, don't go out if you don't need to, and get help when you do. Is that right, Fenella?
Yes, I think the emergency departments and critical care units remain very busy, although our call volume is now, and Kadir will talk about this, but it's probably just above winter average for the time of year now. What we are seeing is that the age of the patients with COVID who are requiring respiratory support is younger than we saw in the first wave, and they are on intensive care for longer. The capacity within critical care has had to be increased significantly, and that's come with the better outcome, the better learning, and the treatments that are available for COVID has also resulted in different pressures, because they require more oxygen and more therapy in order to be able to manage them and get them home. So a lot of good work has really taken place across the whole system to manage this as a system approach, as opposed to silos for each part of the patient journey.
No, very
Just very briefly, although our call volumes have come down, our patient-facing incidents are still very high. With the severity of the illness of a lot of the patients that we're still seeing.
But the approach that you've taken together is really evidence of the progress the Trust has made in quality and reviewing quality, and it gives us some assurance before we go into what is the impact on our performance. So before Kadir tells us that, are there any questions for Fenella and Tricia at this point? Karen? Mark?
Yes, hi, thank you. I think it's not to be underestimated how difficult it is doing active governance within and during a critical event, you know, unlike normally where it's done afterwards. I wonder, first of all, whether you could perhaps give us a couple of concrete examples of how these reviews have changed practice, just as you know, or may led to change during the pandemic. And then also, I guess, what's the plan for a formal collated report of this in the future, so that we actually see what was found and what was done?
Okay. I'm wondering, should we take Mark's question as well, because it probably overlaps, does it, Mark? Did you have a question? I saw you. No? Okay, fine. Sorry, Fenella, go on.
So a couple of examples of things that we have built on during this wave are ability to be able to use the COVID at home. So patients who have got COVID but are being monitored at home with pulse oximeters and are in a virtual ward, we can access their information, we can get in touch with a COVID specialist, and we can make the right decision about the right time for them to be conveyed. We have also set up and delivered a critical care transport service, so that when we needed to, or we continue to need to move critical care patients across the capital, we have got a dedicated service so that the flow of those patients doesn't result in delays to being able to move the next patient into a critical care bed. And all of the changes that we've made in being able to move patients, so instead of patients necessarily going to the first hospital, which is their closest, we've worked with each individual ICS in order to be able to make sure that we're taking patients to where they have capacity for a potentially COVID positive patient, but also where they've got the intensive care and the oxygen availability. And that's sometimes changed on a daily basis so that we have been able to be responsive to the needs of the ICS and their patients. So those types of things. The last one, which is really important to all of us and to our frontline clinicians, is the increased access to crisis mental health pathways, so that patients who are having a mental health crisis, and we have seen an increasing number of those since the third lockdown, whichever has happened, are not routinely being taken to emergency departments, but our clinicians are able to refer them into getting that support closer to home, so that we're not taking them into emergency departments where they would feel even more isolated and even more vulnerable. So some key things. And then the governance that we've put around that is that we have set up an internal clinical advisory group, which has Tricia, myself, operations, and a wide range of clinicians on it, which then feeds into the NHS England clinical advisory group, so that there is a process for agreeing all of these pathway changes and then making sure that we review the impact of them on a regular basis.
In terms of the report, Karen, we obviously, it does take a long time to do this analysis, and we did the same on the last one. So based on the report that we produced the first wave, we expect to have the full report ready for certainly the 1st of April. That's our aim, to get through this analysis and then feed it back into the governance and reporting systems in April.
Thank you.
Thank you. Fergus.
Thank you, Chair. And this is partly linked to Karen's point. The presentation is very clear and very encouraging. But the data we're looking at, of course, takes us only up to November.
Yeah.
In terms of assurance, it's quite possible that the Quality Assurance Committee has seen more recent data, including the trends in the number of long delays. And I wonder if, for the board as a whole, whether Mark will want to say something about more recent data to give us the assurance that these processes are still working well.
Okay.
Thank you, Fergus. So certainly we had a Quality Assurance Committee last week and saw very recent data and aware of the weekly reporting that goes to the directors and the quality team. So we're able to monitor that and ensure that the patients they're reviewing in the judgment reviews that Tricia described are appropriate. It's not just patients that are waiting twice the 90th percentile, but all the others where there are concerns raised. So it is much more robust than that. And certainly at the committee, we were assured that the team are doing everything they possibly can do to provide the safest service they can. And I want to commend the team for the work they're doing.
Indeed, thank you. Pardon? Romuald, would you like to come in?
Thank you. Thank you, Chair. I just want to pick up that last point that Mark made. I think what's evident is that in crisis management, teams come together, and what I'm seeing here is the team has come together well, really well. But I wanted to also just make the point that we need to reflect at some point, when the dust has settled a little bit, on how things have worked or not worked so well for us as a team, but also with our system partners, with locally, nationally, regionally, and the external partners that we brought in as well. So I hope we can come back to that at some point, as we did from COVID wave 1. Let's do a COVID wave 2.
Yeah, or 3. You're right, Rommel. We will have to review that. You're quite right. Thank you. At that point, then, should we turn to what has this meant to our performance and what have we done, Kadir, to try and mitigate?
Thank you, Chair. I think it's, obviously the paper is within my update is within the papers.
Mm-hmm.
I think it's fair to say that the last 8 weeks have probably been some of the most extraordinary and some of the most difficult weeks for the London Ambulance Service in its history. Obviously, we had a number of operational pressures during Wave 1 and took a huge amount of learning from Wave 1 and looked to ensure that those lessons had been learned and we were able to mobilise and be prepared for any subsequent waves. It's clear that the lessons from three lessons from wave one. The first was ensuring that we had resilient call answering. The second was ensuring that we had the vehicles that we could make available and mobilise, and the third was ensuring that we had that patient-facing response. And they were the lessons coming from wave one. In preparation and as part of our response to wave two, we saw extraordinary pressures, both in terms of the volumes of calls we were receiving in 111 services that went from approximately 3,500 to 7,500, calls in 999 control rooms that hit a peak of circa 8,500 from a starting point of circa 4,500-5,000, and obviously our patient-facing response, which went from under 3,000 to over 3,500. The huge pressures that we experienced. What did we do as part of that? We were able to demonstrate a hugely resilient call answering function, and that was delivered twofold. One, through the work that we'd done internally to increase our establishment, and in order to do that, secure call answering, we were also able to make sure that at no point did we have any issues in relation to vehicle availability. The third action in relation to making sure that we had resources that we were able to deploy was a challenge. It was a challenge in relation to the significant additional demand that we were receiving, and part of that challenge essentially emerged from the fact that our plans were built around working with our emergency service partners, who were also experiencing significant challenges in relation to the level of COVID prevalence that we saw in the community in London. Notwithstanding that, we were able to secure and mobilise a significant enhancement in that response, and that is now active within the organisation and across London. An additional action that we took was to significantly enhance our clinical assessment service in the 999 control rooms. So we were able to take more calls between wave one and wave two. We were able to triage those calls and understand the acuity and significance of them. And we were able to ensure that there was a clinical review of each one of those calls in order to make sure that we were supporting those patients while they were awaiting a response. All of that saw at the peak some of our key performance indicators significantly move out from national standards during the height of the pressures. But the actions that we took have secured improvements alongside very latterly a reduction in demand that we've seen over the last week to 10 days. That's culminated in our performance ending last week at much more normal levels of operational performance that you would see during a busy winter period. We also saw significant levels of sickness during the height of the pressures during this wave two, and they are also now on a downward trend, and although still high, consistently and on a daily basis reducing. That's a summary position. I'm happy to take questions on the detail.
So before I open it up, thank you, Kadir. It's fair to say that throughout the pandemic, for Category 1 patients, life-threatening, our performance remained pretty good. It was Category 2 and 3 that presented us with the challenge. And do you want to say a little bit more about what has changed in our practice to make sure we get to those people in a more timely way?
Yeah, absolutely. So at no point was our Category 1 performance for our life-saving response, at no point was that significantly impacted. We did see slight fluctuations above the 7-minute standard, but we maintained a resilient life-saving and Category 1 response throughout that period. In relation to Category 2, this is for our emergency response, that did deteriorate significantly during the height. And the actions that we took were, as I say, to enhance our clinical assessment and oversight of those patients in order to make sure that we were prioritising the sickest and also identifying alternative care pathways for those that perhaps didn't require an ambulance response immediately. And then similarly for category 3 patients, some of whom we were able to support and manage through 111 service provision or other downstream provisions such as primary care.
Thank you. Garrett.
Just wanted to draw out really a couple of learning points from Kadir's report. I think the first around call handling, as it says, we saw up to 8,500 contacts with control centre. Now that wasn't quite as high as the number of calls we were making in the first phase, which I think got up to about 11,000. But of course, in the first phase of this, we didn't have the resilient call handling capability. So a lot of those calls were either repeat calls or they were calls that were triaged initially by the BT operator, which is less than ideal. This time round, because of the resilience we built in and the national links across other call control centres across the country, we were able to consistently answer all of those calls all the time. So we had less calls. And it also meant that we were able to immediately triage all of those patients. So although we had larger numbers of patients waiting in the queue than we did beforehand, it was because we had them all in the system and all triaged and prioritised. So we were able to improve the level of safety that we could assure that we were delivering for patients. So, and that's why we needed to enhance the clinical hub. So that's why we put many more resources into the clinical hub to ensure that we could quickly and effectively not only initially triage through call handling, but actually prioritise and manage those patients in the queue and make sure that we were sending our ambulance resources to those patients most in need. That, I think, worked really well and was a really significant learning from the first phase. The bit that probably is a learning from the second phase already is the speed with which we were able to mobilise that additional ambulance resource, which obviously we had plans in place through the winter plan that we implemented, but the speed of the pandemic growth it basically outstripped the speed with which we were able to mobilise those resources for a couple of weeks. So although we now have all of that resource mobilised with additional firefighters brought on, students and ERs and some Metropolitan Police officers now working for us, we weren't able to quite keep up at the height of the pandemic, which is why the importance of the clinical hub in prioritising those patients was critical. We now have that resource, and although we're still seeing very high levels of patient demand in terms of incidents, we're now meeting all of our performance response standards with that resource in place.
I'm glad you've called out the support we've had from the fire brigade and the police and our student paramedics, but should we also give, we were grateful too, I think, for the collateral support, the national agreement from other ambulance services, for whom we are now providing support ourselves, I think, Kadir, you were telling me.
Yeah, so just in terms of a huge amount of work went in between phase 1 and wave 1 and wave 2 across the ambulance services across the UK to put in place mutual aid arrangements. So at the height of our challenges, we had other ambulance trusts supporting us in terms of call taking, and at the moment, obviously as some of the challenges spread across the country, we have other ambulance trusts who have some challenges in call answering, and we are providing some support to them at the moment. So the mutual aid arrangements between wave 1 and wave 2 have demonstrated a huge amount of benefit in resilience across the ambulance service sector.
Good, thank you. Any questions?
I think it's also fair to say that the support in terms of ambulance division has also been much greater. We've had significant support from South Central and especially East of England through the height of the COVID pandemic, as well as national support from the Contingency Reserve. And again, we're now looking to be in a position to provide that support back as the country goes through a similar experience of the height of the wave that obviously hit London first again.
Okay, so let me open this part up to questions to Kadir and Garrett on performance. Anything anybody wants to raise at this stage? I'm going to Fergus, you look as though you might be. Is that you're just moving? No, okay, fine, thank you. So I think, we have a lot of thank yous to our staff. We are doing our best on the welfare to help them, but we need to keep doing that. Everybody, including the executive, Garrett and the team, have worked exceedingly hard to improve the service we're offering in very challenging times. I think we should note the very significant pressures it's put on everybody, from top to frontline people and call handlers, everybody in whatever bit of the service. So we want to record our thanks to them. This hasn't been about finance or actually about our performance, it's been about safety, but we do now need to turn to the finance report for month 8. Lorraine.
Thank you, Chair. In fact, my update is for month 9.
Oh, beg your pardon, month 9, sorry, I had 8 in my head.
It's in the integrated reports report, but
yes.
As we've heard from Kadir, it has had a significant impact on the forecast that we had at month 8. Just to say, I think the key things to note, the trust was on plan to the end of December with a year-to-date surplus of 1.2 million. And also just to remind the board that since the trust was operating on a financial framework which guaranteed break-even, in this period we're now operating, as with the rest of the system, under a block allocation. So there's a budget. The trust plan, we agreed with the North West London host system that we should reserve a contingency for a second spike. And that was based on the then national modelling, which was the only available modelling. And that assumed a spike of lasting a month and for a sort of similar level of pressure. That amount was 5 million. The current, as Kadir has said, the demand has been unprecedented in this spike and out with all of the national modelling. And our current estimate, based on a sort of pessimistic, more likely case, is that this could carry on through to the end of the financial year at around 6 million a month. And if that were the case, we estimate a swing of 18 million. And that is what is in our forecast. So the forecast has moved from the 2.3 million surplus plan to a 15.3 million deficit. That has been discussed and agreed as a return for month 9 with the North West London system. I think it is positive that the system has recognised that these are cost pressures. We now go into a process whereby there is a contingency that is held within the system and each ICS system. We will now work with North West London to go through a process along with all of the other organisations in North West London to assess the call on that contingency. And that will involve a check and challenge process. We have, and we are preparing all of the relevant information to support that. And as the funding will be dependent, obviously, on not just our position, but the overall position and calls on that contingency. But I think we are in a position where we can demonstrate that within the circumstances that we've applied prudence and reasonableness in terms of the resource response. I have a meeting with North West London CFO to agree that approach over the next week. So as things stand, that is the position, and there is a process for assessing exactly the circumstance, whether the needing to access a contingency has now come to pass. The only other things I wanted to flag is we have a strong cash position at the end of December, and we have, in terms of the actual spend on COVID response, that is now standing at 64 million for the first 9 months. And then finally, our capital programme, we have had a little slippage, as I mentioned, in the action log. We've spent 17 million to the end of December, and we are forecasting to spend our full revised capital budget of 40 million to the end of this year. So those are the headlines. I'm happy to take questions on
Thank you. Questions for Lorraine? The obvious one while we're waiting is that have you been given a timeline for making a decision about how much COVID funding we will get?
Well, I think it's obviously a discussion with all of the CFOs in London. I think the view is that we won't really be in a position until the month 10 return to establish exactly what that is, because the nature of the response is it is quite erratic. And what we've done is to take a prudent view that the resource that we have put on, we've been instructed by the national team to maintain that resilience, that it has to continue through to the end of the financial year.
Thank you. Ronald, did you want to come in? Or?
Thank you, Chair. Sorry, I was just unmuting. The only question I wanted to ask Lorraine, as part of that check and challenge process you mentioned,
I've just done that.
Can we expect any national scrutiny as we did, I think, during the first wave?
Well, I think if everything, if the contingency is sufficient to cover all of the calls, then there won't be any escalation through to the region and above. And I think that's the default is that the systems should be able to deal with their respective organisations. So I think it will only be an issue if, in fact, there is the total call is more than the contingency that's currently held in North West London.
Thank you.
Fergus.
Thank you, Chair. And this, to some degree, is anticipating the assurance report that I know comes later. But I think it's just worth pointing out that as things stand, on the face of the figures that we've got, there is a significant difference between income and expenditure, a significant risk arising from 18 to 20 million additional COVID expenditure for which currently we don't have funding. So that risk is there, and it has an effect both on the control total situation, but also on our ability to forecast cash, which now looks good, but which could change very rapidly if we don't receive this money. That's the first point. Second point is Lorraine has referred to capital, and indeed the Finance and Investment Committee asked for more information on the status of capital projects because we are behind in terms of achieving the amount we want to spend, and Lorraine has circulated that information. I think I'd just make the point that there is a lot to do, particularly around the training consolidation and the bow modernisation, and I think the ambulance consolidation project. So there's quite a lot that we're anticipating to spend in the next 2 months to come into line with the sort of figures that have been projected.
Do Garrett or Kadir want to come back on that? Because it's true, it is a big spend and quite a big concern.
It is true, but I think if you look in the data, you see that we are now spending that money. I think we've gone from spending something like 7 million in November to 17 million in December. So there is a massive ramp up. Focus is right. There is little slack in that programme, and we believe we are largely managing to stay on target with that in spite of the pandemic response.
Okay. Kadir, did you need to add, or you can
yeah, I would have only repeated what Garrett said.
Okay, fine. No need. Thank you. Okay, shall we then move on to where have we got the integrated performance report? Garrett, is that you?
Yeah. So obviously, normally we would take this in bite-sized chunks.
Yes.
We don't have direct render because of the pandemic. So I'm just going to summarise very briefly 2 highlights from what is the report, as I think Fergus already pointed out, up to the end of November. So it's a rather different set of circumstances to the one that we've been operating in December and January. But in November, the Trust performed pretty strongly in relation to our patient outcomes, both in terms of 999 patient responses, and indeed in 111. The only blip in that was in 111, where we slightly missed our 95% call answering target by about 3%, just under 95% target. But all other patient-facing response targets were on track. In terms of our people, our recruitment continued to be strong and on target. Our staff turnover increasingly strong position on resourcing, although as I think we'll discuss later in the BAF, there are some potentially longer term risks to us now in terms of our sustaining our ongoing resourcing. And the only other one that I would pick up as being potentially significant in relation to people was our PDR appraisal rates. We were recovering our appraisal rates following the backlog from the first pandemic, and we got ourselves back up to about 76% against the 85% target. Obviously, the events of the last 2 months and going to REAP 3 and REAP 4 has meant a further suspension in appraisals and therefore PDRs. So expect to see in the next integrated performance report that we will have fallen back against that target again. Obviously, we need to get back on the horse now and get back to where we need to be because of the importance of that in terms of maintaining staff development and engagement. Those were the main things I was just going to point out, but obviously very happy for I or any of my colleagues to take any questions from non-executives.
Any questions? Fergus.
Thank you, Chair. It was very encouraging to see that in November we'd completed 98% of the BA-ME risk assessments and we're working on establishing themes. I just wondered what further developments have happened there. I mean, what are the themes and what sort of specific actions have we needed to take to ensure the safety of our BA-ME colleagues?
I'll probably ask Kim to come in and potentially Tricia as well, because a big part of this is obviously the vaccination programme. We talked about the issues around enthusiasm to take that up. But Kim, do you want to pick up on the risk assessments themselves?
So it's really important that all of our staff undertake a personal risk assessment to understand what the specific issues are for them. This has meant that we were able to do personal response.
Kim, I'm very sorry, but you're coming and going. Could you please speak up and perhaps be nearer to your mic?
Have a go. Is that any better?
It is. You need to stay exactly there.
I'll stay here. Sorry. So it's really important that we all ensure that our BA-ME staff have their risk assessments, and also that if there's any changes, that they're also updated. This has meant that we have that there may be may need to temporarily move them from where they're working. It may be that they have some equipment that they need to ensure that they can work off-site. It may be that we just reinforce the IP&C measures, ensure that the safe working arrangements are in place and that they have adequate PPE for when they're working outside with patients. So we monitor all of those risk assessments as they are produced to ensure that we're meeting everything that has been requested. There hasn't been any particular difficulties arisen as yet. Some of it is around information, making sure that they've got the most up-to-date information regarding how the pandemic might be impacting on them. But at the moment, from the risk assessment produced, there hasn't been any difficulties in meeting any of their particular needs that has arisen to date.
So if I could come in, Kim, one of the things I've been picking up is when people have been off with COVID, they are really not necessarily fit to do the job they were doing. What plans do we have to accommodate people for a period of time, and are they going through occupational health before they come back to work?
So if they've had a COVID infection, then we do seek to see if they are fit to return to their full duties. We are aware that there are some residual difficulties that some staff have had overcoming the infection, but there are some areas around fatigue. We will be taking those, we are working more closely now with occupational health, particularly around individual cases, to ensure that we're providing everything that they need. Phased return to works are in place, assigned to those that may be more vulnerable. So we are looking to see how we can ensure that all of our staff will continue to be engaged in the organisation, so aren't isolated, and that those check-in arrangements, should they be working away from the workplace, are continuing as well.
Okay, thank you very much. Jane, did you want to come in on all of this?
Yeah, one of the things which I'm noticing in the other trust where I'm on the board is that we've now got cases of long COVID, which are showing themselves more from wave 1 now, actually than wave 2. And I don't think we've really had a discussion about that, Kim, here at London Ambulance. So I'm not quite sure whether that's as severe here or it is what I'm finding at the hospital trust. But it's certainly something that we're having to really sort of put our minds to in terms of how we help those people to return to work and indeed what they could be doing to actually feel connected to the organisation.
Thank you, Jane. Anybody else, or shall we move on, accept the report as given? Rommel.
Thank you, Chair. Just a comment and a question, if I may. The question is just on staff assaults, which I noticed were quite high. And just again, from my other trust, where this is becoming quite a serious incident, we've had a particularly serious incident. Yes, and I was just wondering, what are we doing? What can we do internally? Or what are we doing with the authorities, who I understand are beginning to take a harder line? And then the other comment, which was actually a good thing, which I wanted to call out, was to commend the accreditation program and the excellence reporting.
Yes.
And could we see more of that by site and particular area in due course?
I think we're coming on to that under the quality strategy and overview. Patricia, pick that up there, please. But the violence is a big problem. It comes up in the staff survey. Garrett, do you want to pick that up?
What was in the staff survey?
The violence our staff suffer from the public, and linked to, I saw the Homerton had a positive outcome of prosecution in the last week or so.
That's right.
Yeah, I didn't pick up the word. Key word. Yes, I mean, this is an ongoing challenge for us, and as it is, as Rommel points out, for many other London trusts. Sadly, NHS workers in London experience higher levels of abuse, physical and verbal, towards them than we see elsewhere in the country, and we are no exception in London Ambulance Service. So, I mean, we have got an ongoing programme of work that obviously members of the board will be familiar with, particularly the recent appointment of violence reduction officers to support staff, the proactive work with the Metropolitan Police with their Operation Hampshire resources, which is focused initially around violence towards police officers. They've made the full range of their resources and skills and experience available to us. We also have, as part of the capital programme that we've referred to, obviously the development of the body-worn camera project that we are looking to roll out, and I know we're very committed to as a board, and we are taking every opportunity that we can to promote this issue in the media and with public. It is a very small portion of our patients and callers and members of the public, but nevertheless, it's absolutely unacceptable. The nature of some of the abuse that our colleagues are subjected to.
So it's being vigilant, and we do make sure that each person is followed up with, and I think, Kadir, you do that particularly well, don't you?
We do. So both Garrett and I follow up every individual case, both to make sure that our colleagues are getting the welfare support that they require, and obviously Tricia and latterly now Simon's team then follow up, in order to ensure prosecutions are being followed through.
Good, but it is an indictment of the British public, I'm afraid, in London. Really not good, or the population of London, I should say. Okay, thank you. So, if there are no more questions on that, then we can now move to the... Yes, sorry.
Can I just come in, please?
Of course you can, Jane.
Thank you. I just wondered what we are doing regarding the violence prevention and reduction standard that was produced by the NHS in December, and how we're going to monitor ourselves against that.
Good question. Who can pick that up? Simon wants to pick that up. Hello, Simon.
Thank you, Chair. So we are forming a small task and finish group to work through that. We actually just met with the security lead last week, who's bringing that together. He's doing an initial gap analysis for us first before we pull that group together. So I'm happy to share that with board members if that would be helpful.
I think it would. Thank you very much.
Great to see. Yeah.
Okay, great. Okay, so that moves us on to our strategy section, starting with the LAS response to the NHS People Plan. Garrett, are you starting on that?
No, I'm going to hand that over to Kim, who's been guiding to...
Excellent. Kim, back. Welcome.
So the People Plan was published in August last year, following the interim report that had already been published at the end of the year before. The Trust has developed 9 themes to respond to the People Plan, and work has been ongoing. The current position is there are 48 projects that are part of this plan, of which 4 are yet to commence. The ones that are yet to commence are work on a carers network, the wellbeing conversations that need to be incorporated into an annual plan for every member of staff to have that wellbeing conversation, a wellbeing induction process, new members of staff joining the Trust, and to ensure the stability and respect toolkit relating to, specifically around bullying and harassment is the lessons learned from that work. When I say that they're yet to start, I will also caveat that there has been some scoping done on all 4 of these projects. So all 4 are ready to be implemented, to be progressed. Sorry. So the Carers Network, we were waiting for the appointment of the Associate Director of Culture, Diversity and Inclusion, which is now in place, and so the Post Torture there has got that project on their plan. The wellbeing conversations, both induction and annual, are wellbeing scope, and that advert is due to be placed next week. To make that appointment, and the Stability and Respect Toolkit and the Bullying and Harassment is a piece of work that's also coming from the staff survey feedback, but also from the work that's been undertaken to develop the resolution framework. So there's quite a lot of work that's already in place to support all of these remaining aspects. And then the plan, we have 44 completed projects, and we have 22 completed projects and 22 in progress projects that are on track. So that's in a good place. What was also presented to the People and Culture Committee earlier this month was to map the NHS People Plan against the 18-month People and Culture strategic document that was signed off by the board in November, just to check that we weren't missing anything fundamental as well. And these actions and these projects are all reviewed by the team on a weekly basis to ensure that progress is moving forward.
Thank you. I'm sure we'll all be keen to hear about the resolution framework. How far has that got?
So the sort of final draft went to the People and Culture Committee earlier this month. So it's in a really good place. It's been through a number of iterations to make it clearer and more streamlined. It has the backing of our trade union colleagues as well as management, obviously. So it's in a really good place to be. At the moment, the team are working on a training package so that staff understand how it works and the puppets team around all of that. So that plan is to develop those training programs in between now and the end of March for the solution framework.
Thank you. Let me open it up for questions. Jane, did you want to add to that as being the non-exec lead for People and Culture?
Yeah, I've covered some of this in my assurance report later, but yes, we have approved the resolution framework. Tremendous amount of work has gone into that. I think the proof of the pudding's now in the eating, as they say, and we need to get that actually implemented and working well in the organisation, which I know Kim and the team are working on what that rollout plan looks like. And hopefully then for our next meeting, we'll be able to see that particular rollout plan. And then the people plan, which the NHS people plan, which you've got here, we will monitor that at the People and Culture Committee to make sure that it's still aligned with our 18-month plan and that there's nothing that we're missing as we go through the next 18 months. So yeah, that's all in hand. Thank you.
Okay, thank you. Any other questions? Sheila.
Thank you, Chair. Kim, it's really great to see the progress that we're making and everything laid out with the timelines, etc. I guess the question I have is that there's still quite a lot of activity ongoing, and you know, this is against an already very busy team. I'm sure you have. So, I mean, do you have sufficient resources to get this work done? And more importantly, you know, having concluded the work, then how do you embed some of these changes? Because I imagine that's going to take quite a lot of time and energy from your team and others. So just interested in your thoughts on, you know, where you're at with respect to resourcing and support.
You're right that everyone's working really hard at the moment. What we're trying to do is focus on the really key aspects of supporting our colleagues right across the organisation in terms of the response to the COVID pandemic, but also retaining much of the business as usual work as we can as well. So we have taken a conscious decision to keep a focus on all of that business as usual casework, so that doesn't end up being a huge piece of outstanding work to undertake as well. At the moment, everyone is really busy, but we are handling the work, and all of the actions and projects that are in place will need to be integrated and become more robust in the way that we work, so that it becomes an easier process going forward. So they shouldn't be an add-on and a side issue. They should actually be integrated in what we do anyway, to just make the whole system processes more effective in the long run. So we're not asking for any additional resources at the moment, but obviously I know that should that be necessary, the whole Trust is very supportive of the work that we're doing, focusing on the people agenda at the moment and how important that is. Thank you.
And of course, the resolution framework will only work in practice if the managers are well tuned into it. And I suppose I'm turning really to look to Kadir, who has the majority, not all of the managers, but how involved are they in the, when you say training, it's really the change in approach to how we do this, which is very different for the frontline services, perhaps less so to other areas.
I think that's a fair challenge, Chair. Perhaps
all my challenges are fair, Kadir, as you must have learnt by now.
Absolutely. Perhaps Kim and I can take that away and give you an update at a subsequent board in terms of how we are ensuring that join up and that engagement and ownership.
I think it would be important. Thank you. And maybe pick it up at the People and Culture Committee too, but thank you. Okay, so thank you for that, Kim. We look forward to seeing more progress as time goes on, probably as much through Jane's report from People and Culture, but some things need to come back to the board. We can be clear on that as time goes on. Thank you very much. Okay, Garrett, back to you. Do we have Ross, or are you taking the NHS-EI engagement consultation on integrating care? Integrated care systems. Haven't quite got the right heading. Sorry.
You do have me, yes.
Hello, Ross. Sorry, I can see you now.
Good afternoon. Thank you, Chair. So this paper provides colleagues with the final submission that the Trust provided to an engagement from NHS England on improvement about building strong integrated care systems across England. Thank you to colleagues on the board who provided input to that submission. It's really important that the future legislation for the NHS recognises the unique role that we play across London, and that the new framework is supportive of the work that we want to provide as an integrator of services for London across the years to come. So this report sets out our feedback on that consultation paper from NHS E&I, and it's also very much aligned with the response from the Association of Ambulance Chief Executives, who are responding on behalf of the sector overall, and their themes are very similar to the ones that we've responded with as well. So I know that people have been involved throughout, so I won't dwell on this much longer. Final point to make is that at the end of the board papers, there's a brief update on two other consultations that are underway, just to signpost that for members as well. One on the changes to the urgent and emergency care standards, and one on mental health. So the Trust will be developing a response to those over the next few weeks. Thank you.
Thank you, Ross. So questions for Ross. I know that what Garrett and I felt, and other people across the system, that it was nothing like a pandemic to identify for you how a system works and what it would mean to particularly an ambulance service. But everybody, because of the pandemic in each organisation, has ended up having to put in a fairly rushed response because they were not open to an extension, unfortunately. I don't know if people want to pick up here or pick up later on this afternoon. Or shall we note it? Jill?
Yes. Yeah, Ross, could you just, I don't know if you just mentioned this at the end, could you just play back what the next steps are when we're going to hear back?
So I would do if I was very aware of that, Jill. It's a bit of a black hole from our perspective at the moment. So the process will be that NHS England are consolidating the responses to then publish the legislation change that they are looking to enact. It's expected that will be imminent, so over the next few months, but we're very much at the whim of the process within the Department of Health and Social Care as to when that happens precisely.
I think the question is whether, with everything else that's going on, can that really go forward in April 21 or not, or does it need to be pushed back a year? Would be an interesting thing to find out on. But I think people are asking that very question. Okay. Nothing else on that at this stage? So there are the two other consultations, certainly the urgent and emergency and the mental health one link into us very closely into our work. So Ross, how did you intend to involve people or let people know early sight of, once they've got views, what would you like them to do?
So we will share a briefing paper on the urgent and emergency care consultation with colleagues, probably by the end of this week. and we'd welcome any views that people have thereafter. We've got about another month until that has to be submitted. The mental health one we're reviewing at the moment and consulting with colleagues in mental health trusts to understand their views as well. We also engaged with the Public and Patient Council this week on these consultations to get their views on them as well. So we've got a range of inputs we're pulling together. So I will seek feedback from board colleagues outside of the board session more formally and use that to kind of develop our response overall.
Thank you very much. Thank you. That then moves us on to quality strategy overview and progress, and I'm very pleased to be able to give Tricia this opportunity to share with us really how life has changed since she joined us at LAS when we were in special measures, to take us on a journey to where we are now, which picks up on the accreditation point, because this is Tricia's last public board meeting with us before she moves on. She's actually joined us from Yorkshire today, so it gives us an opportunity to appreciate the work that she has done during this time and to comment on it as you've done it. So over to you, Tricia.
Thank you. James, could you take the PowerPoint slides up, please, and I'll go through them. That's okay, share them on screen. Hopefully technology works. Thank you. If you can put it on slide show, James, that'd be great. Okay, so I'm going to take you back. Seems a long time ago now, to 2018-19 when we first set out the strategy. And I just want to remind you the themes that we set out then. And James, if you go on to the next slide. We had four themes there. One was around building the will, and this is about really creating the culture of the organisation around safety and quality. The second was around how we align our infrastructure to support the quality agenda. Third was around building improvement, capability and capacity, particularly around quality improvement. And the final one, clearly, which is of interest to the board, was around how we monitor and assure quality and safety across the organisation. So I'm just going to go through those slide by slide. James, could you put the next slide up, please? Okay, so I think it's really important that we look back at the three strategies and the quality account priorities that we've had over the last 3 years. There is an enormous amount of work in those three documents, which I can't begin to share in this slide deck, but I really want to call out some of the amazing work that's been done by everybody in this organisation. I think certainly if you look at medicines management, Fenella and the team and what they've done, we had an improvement notice in 2017. We are now in a very strong position around medicines management. The same with health and safety, improvement notices, but really strong, and now that being taken forward by CIMA. We have the pioneering services, which I think has been an enormous benefit to patients, and one that everybody in the organisation has been involved in building. And certainly vehicle prep, the estates, the making ready, everybody there has absolutely contributed. And if you look through those documents, you will see an enormous amount of work, which has meant we came out of special measures where we were, and we're now maintaining good. I think one of the key areas which was started by Fenella and picked up with my team laterally, but Fenella and I work together as we always do. Excellence reporting, I think Rommel mentioned it. It started at around 50 per month initially. The highest we had was 93, which was in November. We've now sent out over 2,400 reports, and that's to the line managers and the staff, thanking them for the work that they do every day. And that's really, really positive. It's important we give positive feedback. The teams are, Fenella's team, my team, do learning events across the service at weekends and evenings. There's real thirst for knowledge about learning from where things have potentially not gone as well as we wanted them to. And that's really been beneficial and again has a positive receive from the service. I think in terms of incident reporting, and this is where we see real evidence around the improvements of our safety culture. We are the highest reporting ambulance service, even if you take it as a rate. London Ambulance Service are the highest reporting ambulance service for incidents when you measure us against the National Reporting and Learning Framework. I think you saw last year on the staff survey, we were improving dramatically in terms of feedback, reporting, people feeling safe to report. And I'm very confident that when we see the next staff survey results, you will see continued improvement there. And I really believe we have a really strong patient safety culture now. I remember when Garrett we used to do in the old days the station visits, and staff saying they didn't feel supported when serious incidents happen. I doubt you will see that now, and if you do see it, it's an exception. There is absolutely a recognition that they are supported when things go wrong. And clearly we're training people in terms of root cause analysis, which will help us in the future understanding why errors happen and how we can improve on that. And I think I'll talk a bit more about the quality hubs and station accreditation, but really positive engagement across the organisation and really proactive and willingness for people to be involved in all of the quality and safety agenda. So I think in terms of building the will, I think we certainly have it's testament to our staff and all of the directors in terms of their focus on the quality and safety agenda. Next slide, James. Okay, so this is about building the infrastructure and aligning to that. Clearly, as you know now, we have really strong project management infrastructure. The strategy team really feed into that. It's aligned to all our business plans. All of the quality priorities and accounts are aligned to all of these main programs of work and our strategies. And we have a really strong, robust governance around those processes now, where we didn't even have a project management function when certainly the majority of us started. Certainly, quality impact assessments are done on all projects, and as we know, in terms of contract management, they're all done. Fenella and I sign them off. So a really robust process around quality impact assessments. We plan all of the quality accounts and annual accounts around our business plans, and it's based on analysis and risks. So clearly we have implemented Health Assure, which is a website documentation information system that really tells us where we are from station to board around our quality standards, and it's linked to the key lines of inquiries from the CQC, and all the station staff use that regularly now. We monitor against that. We have the quality governance roles in every sector and every service now. The quality governance and assurance managers are there. We have them now in EPRR, in EOC, in areas that we hadn't got them before. And along with Fenella's team, the senior sector clinical leads, they really are working closely on governance, assurance, and the clinical effectiveness agenda at every level. We also have made sure that the locality general managers, the CTMs, clinical team managers, I won't use an acronym, have also got quality in their job descriptions. I think we've developed a methodology which has supported the redesign of services and the infrastructure, particularly the pioneering services, as I've said, is an absolute, a real tantamount to people's work on this and a real benefit to patients. And that has involved everybody in developing, and it's now being operationalised. Mental health team, as you know, are out there delivering the service every day and aligned to Kadir's operational delivery, and the end-of-life team also along with the maternity team. We've certainly developed the business intelligence and the informatics now. We have comprehensive data sets on every area, again from station to board, and which we report through our governance processes, and I'll talk a bit about those in a minute. And clearly our infrastructure is moving forward very rapidly as we grow as an organisation, and making sure that we absolutely align the quality governance and assurance and the safety systems and processes we have, not only in the nines, but also in our new integrated urgent care areas. And the aim with our new quality hubs is that we really push out now quality teams into our new ambulance modernisation programme, with the aim that they will sit out in the sectors, and sectors will be responsible for and take ownership of the quality agenda, supported by the corporate team rather than the corporate team potentially doing the doing. If you go to the next slide, James, that's just an example of how we see the quality hubs. We have had business partners in the quality team for every single dimension and function around quality. We are now pushing them out, and every sector now has that business partner working with them. And as I said, the aim is that it absolutely is owned by the sectors, and quality and safety is taken responsibility to the new ambulance modernisation programme, so everyone will have a quality team, and that they will be linked into the management structure within those ambulance hubs. So that's been trialled. We are working closely with Ross's team and the strategy team to take that forward alongside that development. Next slide. So this is where we get into the assurance. I think when I started, and Fenella and I worked closely on this along with Philippa Harding, to set up a really strong governance and assurance model that is absolutely from station to board. When I started, we had one meeting, overarching meeting with about 6 groups attached to it, and not particularly strong sector involvement, or we didn't have that sort of golden thread from station to board. You will see the number of groups we have now, and that ends really on the independent assurance we have with our commissioners, our stakeholders, our system partners, who are really positive and very supportive, both in the Nines and the integrated urgent care setting. Fenella and I meet with them regularly. Very supportive, positive relationships around the whole governance and assurance. So really strengthened that quite dramatically over the last few years. Next slide.
Could I just see the slides? They're now not coming up. I don't know what's happened.
Have you got them on your, you should have them in your pack. James, have you got, can you get them on or not?
They're coming up for me.
Oh, there we go. So we're on station service quality accreditation. That's now. Right. Yep.
Okay, thank you. Karen can see them, that's fine. Okay, so Rommel mentioned this. Again, I'm going to say a lot about being the first ambulance service, because we are in many respects. We are the first ambulance service to implement station and service quality accreditation. And this is a reflection of what the acutes have probably been doing for some years, which is assessing all the stations and services against the key lines of inquiry from the CQC methodology, and using our Health Assure to inform that. So the stations collect the data regularly. We have now piloted the review. We had the commissioners, we had our patient and public stakeholder groups being involved, various members of public involved in doing these assessments. So from the first 5 that we have done now, the stations you will see, Hanwell, Wimbledon, Camden, Newham, had gold status, and they are fortunate enough for Fenella and I to be giving them their awards on LES Live on February the 10th. Brixton only just missed out on the goal by 1 or 2 points, and they're feverishly trying to get to the goal. We absolutely have had really, really positive feedback on this, both from everybody involved, including Patient and Public Council and our commissioners, and we're absolutely, the stations are now ringing us to say, can we be next? So we know it's beneficial. It's shown some really good improvements. We had measured real KPIs as well as the soft KPIs in terms of how people thought about it. So we will be rolling that out now across the organisation. We just need to get the go-ahead from the Quality Assurance Committee. But again, certainly other ambulance services are looking to us to find out what we're doing around this, because they're really interested. Okay, the next slide, please, James. Again, I'm going to say we are the only ambulance service who have been chosen to take forward the Patient Safety Incident Response Framework. This is a new national framework which is really moving us away from that constant individual analysis of individual incidents and more towards thematic approach to incidents, and the real focus is on learning and feeding that into quality improvement. So we have adopted that framework. We've helped develop it. It was signed off at the Quality Assurance Committee at the last meeting. We will work with NHS-INE and other ambulance services to develop that, not just for ambulance services, but also for the wider NHS. So that is a real coup, I think, for this organisation. I think we're going to be really instrumental in developing this and understanding how we can learn in a thematic way, rather than spending a lot of our time just investigating incidents that are potentially got the same common contributory factors. So we've identified those 7 themes. We will be taking these forward, and we have got a quality improvement plan aligned to this. So
very good.
Patient Safety Incident Framework will support the quality accounts and what we need to do, because it's risk-based, and it will also be informed by the station accreditation programmes going forward. The real key for us is to really learn about delays and the COVID. That's our first quality improvement programme into the plan. Okay, next slide, please. Alan would never forgive me if I didn't talk about safeguarding. So I just want to mention Twiddle Bits because they are absolutely being positively received across the organisation. I think the staff love them because they really do allay the anxiety of patients with dementia, and they really do calm them down. I think 3 years ago, the safeguarding team were probably not necessarily high on everybody's agenda, limited in terms of resource and their involvement, but they have absolutely come forward in great strides with Alan, and I think the Quality Assurance Committee would agree that their annual report was really exceptional. So again, we are the first ambulance trust to, well, I think to have twiddle mitts certainly, and contextual safeguarding referrals. So this is where we gather and we identify referrals from high-risk areas, potentially things around youth crime and also modern slavery, things like that. So we are now working to feed that into the system to make sure we alert them to any risk that we find around safeguarding. And we're just introducing a Youth Alliance project, and this is mentoring children who are homeless children, and so our paramedics are working to support them, talk to them about the work we do at LAS, and really just being a shoulder and an ear to listen to their issues and problems. And again, we are now rolling out the child protection information sharing across the organisation. So a massive amount of work from safeguarding. I can't say enough about what we've done. It is an enormous amount of work. Next slide. And finally and clearly, really importantly, we now need to really push and take that step change around quality improvement. We've now trained over 200 staff in the quality improvement methodology. We are developing an e-learning package, and that should be rolled out in April, slightly delayed by COVID, but we've rolled out in April, so we get more and more staff. 75 key individuals, so they have the higher level of training who will be supporting the quality improvement hubs as we go forward, so trying to make sure we align all of these skills to different sectors and that they have the right number of people to support them taking quality improvement going forward. So next slide. I think that was a whistle-stop tour. I can't really tell you, but I will say the organisation has absolutely transformed since we all arrived in a really positive way. I just can't recognise it from when I started. So I think, we've talked about it today. Continue to learn from COVID is absolutely critical over the next 3 to 6 months. And I'm really talking to John Martin, our new Chief Paramedic and Quality Officer, about the quality account. We've already started talking about that and started to refresh that so he can pick that up when he comes. So we're aligning all of these strategies, the patient safety framework, the business plans, and the new CQC strategy, which we are going to be consulting on the board members next month. But clearly their key areas are around patient and public engagement, around quality improvement, around inequalities in health, and really learning from incidents. So there's a real focus on those areas from the CQC. And I think clearly cultural change is one of the areas we know we're all working on. So we just need to carry on now, really getting those areas developed, implementation of those patient safety plans, the QI hubs, the station accreditation. And one of the areas we are working on, and again, I've talked to John about this, is making sure we have the quality assurance and governance processes in integrated urgent care that match the same robust processes we have for the nines. We have got them, but we do need to re-look at them. And part of that will be looking at the structures we have in the quality directorate to look at efficiency savings, Lorraine will be pleased to know, but also to make sure we're fit for future purpose in terms of our resource. Next slide. So it is a final thank you, goodbye tension, hello pension, was my mantra. I'd really like to thank specifically Garrett and the chair for their support to me over the years. It's been immense. And to all of you, the non-execs, really appreciate your support and advice and your constructive challenge, although I do say I might not miss the word assurance when I'm retired. I think I can't speak highly enough of the staff. I think we all know our staff go way beyond in terms of delivering the high quality care every single day. And I think we've certainly seen that over the last year with COVID. But it's corporate staff, operational staff, everybody has been engaged in this journey and brought us to where we are today. My team particularly, I'd like to just say thank you. I mean, I probably had about 10 teams to manage at one point, but for all of them, I never failed to be impressed by their hard work and dedication. You know, all the training they do it at weekends, they do it at evenings. They are a brilliant team, and I'm sure they'll work closely with John. My exec colleagues at the end, your support and friendship, I think, has been invaluable. I've really enjoyed being part of the team. I want to thank Fenella specifically, because I think she'll be my forever friend. I get emotional now. So it has been a roller coaster ride, but I'm glad I didn't miss it, and I wish you all well in the future. Thank you.
So let's have Tricia back. Tricia, come full screen. You were very gracious in thanking everybody else. And before I say anything else, I just want to hand over to Garrett. It's gone quiet.
Thank you, Heather.
Well, it's got nothing to say.
Well, be careful or I'll go in again.
Well, because I was coming off, but I realised I was already off mute. Then I was tracking back on what I might have been saying whilst Tricia was talking. I think I was quiet. Tricia, I just really wanted to thank you on behalf of myself and the executive, and I'm sure Heather will do likewise from the wider board, for everything you've done over the last 5 years or so now. You have been instrumental in leading the team to lead the organisation from where we were in 2016 in special measures and being described as inadequate to where we are today, which is a strong, good trust, performing well in incredibly challenging circumstances. Still, as we all know, so much more work to do, and you've articulated that at the end in terms of the journey, but you have set us on such a solid course, not only in terms of quality, but actually in terms of, you know, the whole range of metrics and performance and judgment by which we are regulated and judged. So I really wanted to say thank you to that. You mentioned our successor, John Martin. I think it would be just recording for the board. We announced formally yesterday that Dr. John Martin will Tricia on the 1st of March. John is a qualified and practicing paramedic and also a director at Cambridge and Peterborough Foundation Trust with vast experience across the NHS in the quality agenda, but also somebody who started their professional career at LAS as a paramedic. So to some extent it's a coming home for John. And John takes on a revised remit of quality and chief quality and chief paramedic and quality officer, if I get it right, and will take over leadership of the education, training and standards for the paramedic profession across the organisation. And John is also currently chair of the College of Paramedics. So I think in John coming to the organisation, we'll be able to take some of that next step in terms of the continuing professionalisation of the profession, the culture change that we need to go on more broadly, ensure that we move to the next level of delivering standards. I think it's the right thing for the future, but I can't underestimate the huge contribution that Tricia's made to the organisation. And it's also reflected, although we'll be talking about it later on this afternoon, in the transformation that she's achieved within the Quality Directorate. So I think this is the only opportunity we'll get to say that, so I will say it. So just really wanted to say thank you and hand back to Heather.
Thank you. So returning Tricia, you were very gracious thanking everybody else, but we would like to thank you for your leadership. We wouldn't have got to where we've got to without you. Your presentation, yes, I would say you'd get a standing ovation, not just for the presentation, but for what you've achieved in 5 years, and my colleagues are silently clapping you. So thank you so much, and I'm sure you'll keep in contact because you'll be marking our homework to see how well we do and all the tasks we have left. But it has been some journey, stressful at times. So I'm sure your colleagues will miss you, but thank you very much. Thank you.
Thank you. Thank you, Chair.
Okay. So actually, while we're on thank yous, and before it gets to the end, it's not just Tricia's last formal meeting, but it's sort of Fergus's, because I'll talk about that later, but also Fergus was here before any of us, even Fenella, I think. Is that right, Fenella? Had you joined the Trust when Fergus joined as a non-exec? And as everybody knows, Fergus has been a phenomenal non-exec. He's done 2 terms with us. He's been the Freedom to Speak Up non-exec, and he's done that with such panache, delicacy, but thoughtfulness for the executive as well as for the members of staff who've wanted to raise issues with him to help us, actually to help them, but also to help the organisation move forward. And of course, he's had a phenomenal role working, particularly with Lorraine, but with us all on the Finance and Investment Committee. But he's had a we're going to miss our very wise, thoughtful Fergus. And I'm really, really worried about when somebody says, what was X in X year? And Fergus always turns and he's got the file and he knows the date, he knows the meeting, and you've got it precisely. And I'm just looking around thinking, who's going to take that on? So we also owe a great debt of gratitude to Fergus. So thank you to Fergus. And I thought I didn't want to get to the end of the meeting and be rushed in not doing that. We will really miss you. Thank you. And you are allowed to speak if you like, Fergus, before we move on to finish the meeting.
Thank you. Thank you, Heather. Those are very kind words, and you've taken me a little bit by surprise.
It's the aim.
I'm reminded of the fact that when I first joined 7 years ago, one of the things that one did fairly quickly was to go on a ride out.
Yes.
I went out with an ambulance, and I've been on a few since, but I've never forgotten how impressed I was with the things that were done that day, the achievements of the team, their compassion and all the rest of it. And it strikes me that in a way I've been on a long ride out, 7-year ride out, and a lot of exciting things have happened along the way. The major incidents that we've had to deal with as a trust, COVID, of course, the higher standards of care that Tricia's been talking about, the closer working with the system that we've developed, the way in which we've moved into 111, the great improvement in our staff survey results, the way in which speaking up has improved, and in fact the award that we won a couple of years ago for the most improved trust in freedom to speak up. The progress we've made with diversity, although there's a huge amount yet to do, the strong financial discipline that I think we've had throughout this whole time, the way in which our strategy has changed and developed, and of course the ambitious plans that we've put together out of that strategy. So it's been an amazing journey, and it's been a great pleasure and a great privilege to be on that journey with the Trust. I've had some great companions on the journey. The many people in the organisation that I've worked with, the finance team in particular, and the Freedom to Speak Up team, those who support the board, not to mention the frontline staff that I met at many points along the way. And I think I should mention some former board colleagues whom it's been a pleasure to with Richard Hunt, Fiona Moore, Paul Woodrow, John Jones, Theo Depensier, Robert McFarlane, Philippa Harding, Jessica Cecil. And I'm sure I've missed people, but there's been some great people along the way, which of course brings me to my current colleagues on the journey. And I think it's been quite remarkable how well we've worked together in this remote working context. And I think that shows what a strong and cohesive team that you have put together, Heather. We've had debate and challenge, but we've had a very, very constructive interaction together, very much in line with trust values. And I think for all that to happen, for a journey like that to work well, it needs a good map and a good driver. And I think we've had really great leadership from you, of course, Garrett, and it's been a really great pleasure to work with you. And from you, Heather. We've had some robust debates, I think it's been today, but I think you have always been committed, positive, experienced and aware of the human dimension of all of the issues that we've talked about. And it's been a real pleasure to be on this board under your leadership. As I look forward, that's the end of my journey, my ride out with the ambulance service. So in future, I'll be looking at that journey from a distance. There's much more to do, and I really wish every success to the Trust in terms of the implementation of the ambitious plans that we have. So I suppose the next ambulance journey I make may well be in the back of it.
Not.
When they hand me my, what are they called, twiddle mitts, I know I will have very great confidence, not just in the team that are in charge of that particular ambulance, but in the whole organisation that lies behind it. And it's been a very great pleasure to be associated with getting it to the very great stage that it has now reached. So thank you, everyone.
Well, thank you, Fergus. Now, you've got one more task to do, which is to feed back on the Finance and Investment Committee and the Charitable Funds. So
Indeed. Thank you, Chair. I called the Finance and Investment Committee meeting, in fact, a tale of two meetings, because we had an emergency meeting to discuss some contracts, and then a rather truncated main meeting. I also called it an AA meeting. Nothing to do with vehicle repair and nothing to do with addiction. It was around the fact that we were focused on assurance and approval. So the 3 points we wanted to escalate to the board, for the board.
we lost you, Fergus. Fergus, I think you've frozen. Apologies to the members of the public. We've got a technology issue. You're back. Fergus, we lost you. You had 3 points you want to bring to the board.
Yes, sorry that I went into the ether there. First point was the fact that we've approved these contracts for blue light services and additional 111 services. Second point has already been, I think, pretty well covered, which is the fact that those contracts and other activities have resulted in expenditure beyond the contingencies that we've had for COVID, and therefore at this point there is a gap between projected income and projected expenditure. And the third point again has been discussed earlier, I think, by Lorraine and Garrett, which was the position around capital expenditure and the need to make sure that we stay on track to spend what we've got and keep those major projects that the board has approved on track. Those are the 3 points for escalation. I would just also bring to the board's attention the considerable progress that I think has been achieved under the leadership of Lorraine and Nick Young related to procurement. Our procurement is covering over 100 million a year. We've made progress in terms of the percentage of that that's covered by contracts. There are now category plans covering the whole of that. And I think a great deal has been achieved. But the committee was very conscious of the fact that to make this work is not just a job for procurement. It really does need the commitment and engagement of the senior leadership throughout the organisation, in particular to make sure that those category plans are delivered and that the new procurement processes are respected. We will be having another meeting in February, which will move away from approval and assurance, and we'll be looking at forward planning. And I'm sure my successor will be able to report on that in March.
Thank you very much. Have you finished?
Yes.
Yeah, lovely. Thank you. And do you want to do charitable funds? Then we'll just come back and see if there are any questions.
Well, on charitable funds, I think the main task will pass to Lorraine, which is the approval by the board as trustees of the charity of the annual accounts. And there are a couple of points that I'd like to add, but I think I should pass the responsibility over to Lorraine.
Thank you.
Thank you, Lorraine.
Yes. Thank you. So we have before us to approve the annual report and the financial statements for the London Ambulance Charity for the year ended 31st of March 2020. So just to say that these report and accounts have already been reviewed through the November Audit Committee and the Charitable Funds Committee, which met on the 19th of January and is supportive and recommends approval. And just to note that the transactions within the last financial year are relatively small. We noted that the cash balance at the end of this period was 250,000, which is a small increase on last year. The income was 41,000 and expenditure was 16,000. I think just to note that in the annual report, there is the intention to significantly increase the scope. I think one of the sort of consequences of COVID actually has been that there are now many more sources of funds, which I think we will be able to secure through the, amongst others, the NHS Charities Together. But what I am asking the board to do today is, as corporate trustees of the charity, to approve these annual report and the accounts, to note that they have been independently examined by Ernst & Young, and that is not a full audit because of the size of the charity, but that the audit and examination determined that there was nothing exceptional to draw to your attention, and that we will then proceed to submit the report and accounts to the Charity Commission by the 31st of January.
Thank you, Lorraine. So can we approve the Charitable Funds accounts? Yes? Everybody say yes, they're approved, Lorraine. Thank you very much. That moves on to then Quality Assurance Committee. Mark.
Sorry. Chair.
Oh, beg pardon.
Sorry to take up a bit more time, but just coming out of the situation of the charitable funds, I think it's important to note that we faced two challenges. One was that the charity had not been spending all of its funds in the year that we just looked at. A lot has been done to change that, and I think Lorraine and Michael and various other colleagues have pushed that forward. But beyond that, the funding of the charity is increasing, and therefore to respond to that, we need to make sure that we chart the right course and that we have the right governance in place to ensure that we continue to spend the money in accordance with the charity's objectives and do so at reasonable speed.
Thank you. And Garrett, I hope you're going to say about a fundraising event, are you? Or something else?
Yes, I just thought it would be appropriate at this point, talking about the LAS charity, to pay tribute to Sean Ash, who, our emergency call handler, who I think many of you will know, suffered from terrible irritating illness last year and is unable to walk freely. Sean has been raising money for the LAS charity over the last few weeks. He set himself a target to walk a mile with his swimmer frame in 2 half-mile chunks last Friday and the Friday before. And so far to date, I understand he's raised a total of £60,000.
Amazing. Amazing. We need to write to him. I'm sure you will do that, but I'd be happy to do so as well. It's just amazing, and it's still open, isn't it, Garrett? If anybody feels they'd like to ask their friends and family to contribute. Pauline, do you have is it on Facebook or is there a...
We've got it on our social media channels and we can get it on the website.
Excellent. It's on our social media channels and on the website. So do tell your friends and family about that. That would be great. Thank you, Garrett. Well done. Thank you both. So moving on then to quality and clinical care. Mark, assurance, please.
Thank you very much. Very little to say. You've got the report and we've discussed quality, and Trish has highlighted most of what we reported, which is a long discussion around the patient safety incident response framework. Also just want to draw your attention to the growth aspect and the reports that are appended at the end of the, and this was the STEMI reports that are appended at the end of these papers. well worth a read to look at what Fenella and her team have been doing in the year. Happy to answer any questions.
Thank you. Any questions for Mark? Other than from me, it's not a question, but it's a comment. It was so good hearing from Tricia all the things that have happened in quality with colleagues. If we can find more time to do more clinical presentations, I think that would be really helpful. So perhaps we could think with Simon and Garrett how we could fit that in, Fenella. Focus on real patient journeys.
Yep.
Thank you. Okay, so that moves us to people and culture. And Jane.
Thank you, Heather. Yeah, we've talked about a number of things on my report, but I'd just like to pull out a couple of them which are on the first page. As you know, we've got much better latterly at workforce planning, and we received the workforce planning report at the PCC, which recognised that there are only about 200 paramedic students graduating from our partner universities this year. Which, as we had expected, I have to say, it was necessary to think about other options. And whilst Kim and the team are working together with the education team on what a pipeline will look like going forward, that's not going to be enough for 21-22. So we will need to go out to recruit 269 international paramedics in order to achieve our workforce plan for 21-22. Now, you'll know that's been incredibly difficult over the last 12 months, as we would normally go to Australia. And of course, that's been incredibly difficult for us to recruit people there and for them to travel. So the proposal that we agreed was to link up with an external recruitment agency that was not just for Australia, but looked at other countries where we may be able to recruit, good paramedic graduates from, and they will help us with the whole process of doing that. That's not to say we won't do anything in-house anymore. We will. It'll be a combination of doing both. And we said at the PCC we actually have to get onto this really quickly now, because if we want to have people ready to come to us for the latter part of this calendar year, then we really do need to up our game and get on with that quickly. And I know Kim and the team are looking at that and have identified people who will work with the agency in order to do that. And the second thing that came, which is linked to the strategic workforce plan, is our plan to significantly increase the number of TEECs that we bring into the service as compared to the prior year. And with needing to bring on board so many, which actually fulfills what we wish to do with our skill mix going forward, then we will need to use an external partner to help us to train those people. So it's not to say that training won't go on in-house, but in order to be able to accommodate the additional numbers that we want to bring through, then we will engage with an external partner. The good thing about that is that we can cover that through our apprenticeship levy, which we pay anyway, and we can use that to actually pay for the training of those TEECs. So the PCC, whilst wanting, of course, always to try and have an internal pipeline, recognise the fact that we do need to do both in terms of our international recruitment and some help in training the TEECs as we go forward. I think other things we've pretty much covered. We did have an update from ATS on the culture, diversity and inclusion, and he's going to be bringing us an overarching plan for the rollout of everything that we know still hasn't been achieved, and some things that we might know that actually we would like to get onto, and he's going to bring that back in March. I know we're discussing staff survey a little later, and we've already covered wellbeing and the resolution framework. Probably the last thing for me to say, because we've already spoken about sickness as well, is the employee relations team gave us an update at the PCC, but we've had a further update since then to tell us how much of the backlog employee relations cases that the team have actually been clearing. And all credit to Kim and the team. We've now moved from open disciplinary cases at 62 in November to 13 as of not the 19th of January. So a reduction of 78%, which is quite fantastic. Suspensions have gone from 6 to 2, 66% reduction, and grievances have moved from 20 to 4, and that's an 80% reduction. So I think the team need to be congratulated for working through that in earnest in the way that they have. And that should put us on a really good platform for bringing in the resolution framework, because no longer will we have all of those cases out there that we still need to cover off. So well done, Kim, and well done the team for moving us in the right direction through that. I think that's all I want to say. Thank you, Heather.
Thank you. That's really good to hear about the outstanding cases, and perhaps we'll pick up on that later, but well done to the team, as you say. Thank you. That takes us to Board Assurance Framework. Sima, welcome back.
Thank you, Chair. Thank you. So in relation to the Board Assurance Framework, or the BAF as we nickname it, there are two matters for the board to function on. The first is in relation to BAF Risk 61, and that's related to COVID impact. Recognising the increase in the risk ratings that the board committees have approved, the executive are making a recommendation to the board that we take an action away today to just consider the longer term risks that are arising out of COVID, and particularly in relation to the people risk, governance and funding risk that we've touched on today. The second matter for decision is to remove BAF Risk 62, and that's in relation to EU exit. The board will recall that there was a risk relating to supply chain, but we've not seen any material risks surface for that. So the executive are recommending that we remove that also.
Thank you, Sima. So let's do it in reverse order. The Brexit risk, are people convinced that has now gone away? There's no supply issues or anything outstanding? Might be AstraZeneca or Pfizer, but apart from that, does anybody want to comment on that? Jane, did you want to comment, or your screen went up? No, Sheila.
I guess on the supply chain, I'm just wondering if it's a little bit soon to declare victory from that perspective. So whilst it may not remain a BAF risk, I think we'll need to have a running report on any supply chain issues as they arise, and make sure we have sufficient mitigations in place and continue to monitor that.
Thank you. Garrett?
I wouldn't disagree with that, but I think probably there's a similarity between these two issues here, that the risks that we may well have going forward probably are going to be more specific than general Brexit or COVID risks. It might be a specific risk in relation to one particular supply chain that we might need to monitor and manage, and it may or may not make its way up from a corporate risk level to the BAF and so on. But I think to talk about an all-encompassing Brexit risk, I think that has now passed, because Brexit is
so the proposal is to remove it from the BAF, but to be mindful of any other supply chain risk and bring those onto the risk register and raise up to the BAF if it's deemed necessary. Is that proposal acceptable to people? Yes, no dissenters, no, I think that's a yes, we'll do that then. Thank you, Simon. And then turning to the first one, which really we've covered off quite a lot of the conversation in the meeting around the risks around COVID. So the proposal is the executive take that away and reconsider it to see what their assumption is at the end of that. Would that be for the March meeting, Simon?
Yes, Chair.
So do you want to remove it for now or leave it where it is?
So we'll keep it on for the board today for approval, yes. But at the next March board it will be different. It won't be in its current format. So it will be presented, as Garrett says, zooming in on the specific risks.
Did you need to add to that, Garrett?
Well, yeah, I mean, we need to do some work, and probably those risks that we have identified, we'll need to understand at what level they are. I mean, there are things like, longer term implications on staff retention, recruitment, and things like that we now understand more about. I think when we introduced this risk 12 months ago, the reaction to the initial sort of advent of the pandemic, and the easiest way to manage the breadth and scale of that risk was to the risk on a thematic basis that tied in with committee structure. It seems like we've probably moved beyond that now. We have a much greater understanding of where there are significant potential future risks and where actually we're now on top of some of the original issues.
Okay, so we're agreed with the proposal. Yes? Any dissenters? Is that a question or a Fergus? Is that a question?
It's a question, not a dissent.
No.
And it's really around the way in which we've worded the recruitment risk. We say that our ability to retain and recruit clinicians will be affected by the changing landscape of the NHS and the opportunities for paramedics to be employed in other areas. It sounds to me from the conversation, from what Jane has said, that the risk is much bigger than this. It's got international dimensions, it's got academic dimensions, university places and so on. And I just wonder if we need to think more broadly about how we express that risk.
So I think that's probably the suggestion that is on the table, that the exec go away and do exactly that and then come back with a more refined one. Yes? Thank you. Oh, Sheila?
Yeah, thanks, Chair. I just in terms of Gareth, your point around, taking this COVID risk and honing in on the more specifics. I'm just wondering, I mean, do we need to do some wider scenario sort of assessments, looking for, where are the black swans, as we call them, around COVID and some of the, potential things we can't predict right now, but perhaps getting some people together to look for, where might there be some additional consequences that we can't, necessarily identify right now. But, we talked about long COVID a few minutes ago. We're talking about people coming back, trying to come back into the workforce. We're talking about, the impact on our people, mental health issues, etc. So just feels to me that, the risk as it's described, we might need to sort of refresh it completely and look at, what are those sort of big ticket items that we can't ideally predict right now, but we should be starting to highlight.
So not just the obvious. I think it is in line with what Garrett and Simon are suggesting, but you're taking it a little bit further.
I think we're discussing to agree, really, because I think that's exactly what I've got in mind, is to look at some of those specific issues that
So on that proviso, are we happy to content to agree with that proposal as well? Yes, a broader. Thank you. That brings us to any other business. So, no any other business. Shall we just reflect on how we've done? I just wanted to summarise, but maybe we'll reflect on where we have been first. How did we do today? Is there any comments? Do the executive feel listened to, supported and equally challenged?
Yes, Chair.
Yes, that's the right answer, Chief Executive. No, seriously, is there any feedback people want to give? I know the papers were late, that caused some problems, but most of it was pandemic related or not having the information from commissioners. But it does make it, as we all know, difficult for everybody to have read them. So we need to go back to making sure as soon as possible we get the papers out in good time. So apologies on behalf of everybody for that, really. So anybody want to add anything?
Just, Chair, just to say that I think, despite the papers being late, I think the 3 introductory papers on COVID were very clear. So I think giving us an update on where we're at around issues around people, the clinical quality of the performance, I mean, I think it was, they were very well done and aided the discussion.
Thank you. So I think we did focus on COVID and, 2 areas, our people and the welfare of our people, and the sickness, vaccination, very important, where we've done tremendous work, and how we communicate. We can't give enough thanks to our staff, but neither can we give enough focus to getting better at all of these things. For everybody has that challenge, and we took some assurance, I think, that much more work is now being done, but we keep going. And on the quality in clinical care, really tricky one in a pandemic, to know that our clinicians cannot always give the quality of care that they would like to give, but that we have been assured that we have systems and processes in place to be assured that we are being as safe as is reasonable in the circumstances, and where things perhaps do not seem to have gone well, that we have a system to review them. And our performance, we've had explanation about what we've done to put more resource out there, but where the challenges have been. And good to hear that as of about now, things are beginning to return to normal, but hospitals remained under pressure and the public remained very sick. The big issue on finance, I think, is that we are dependent on getting the COVID funding, and if we do not, we would have a deficit, which is a conversation we would need to be having elsewhere. But we are noting that that would also have an impact on cash as we go forward. But I think, Lorraine, you are reasonably optimistic that we will get, if not all of it, some of it, I think is the answer to that. We've looked at the strategy for the people plan and have some assurance of our response to that, of work ongoing. We've looked at the integrated care consultation and our response. And then very importantly, we've had a very good summary of all the work that's happened in quality and the position that the Trust is now at. And I was thinking, if the CQC wanted to visit now, and maybe they're on the call, I think that is very good heritage. So once again, thank you to Tricia and everybody else who's worked on it. And equally, to my thanks again to Fergus for everything he has done over a protracted period for this Trust. We've reviewed our risks in the light of what is now happening and our BAF. So I think that brings us to the point where, if nobody else would like to make a comment at this point, last opportunity, board members, no, then that closes the meeting held in public on the 26th of January, and our next meeting will be on the 30th of March. Thank you very much, everybody.